So we're going to move swiftly on then to Community in Action. And I'd like to introduce somebody who I've met recently. I met him first on Twitter when he did his first pledge for 2013. And then I actually met him at Confed this year, and that's Dr. Jonathan Griffiths. And we're also going to hear from Emma Donaldson, who I also met over Twitter, I think. And so welcome to both of you. So Jonathan, you're going to be on first, and you're going to be talking about your pledge where you spent some time on the reception in your GP surgery. And then I think we're going to go straight to Emma, and then we're going to have the questions and answers. So a very big welcome, Jonathan. Lovely to have you here, and it's over to you.
Thank you, Jackie, and apologies that I can't get my webcam working, but I hope everybody can hear me.
Yes, I can hear you well.
Great. Hi, Jackie. Nice to see you again. I can see you at least, even if you
can't
see me. And thank you. And
hello, Jonathan.
Hi. So I'm
just quickly, Jonathan, your camera should work now.
Jonathan, do you just want to try your camera?
Oh, okay.
Do you want to try your camera again? It should work now.
Okay, looks like it's about to work. Yes, how's that?
There you go.
Okay, thank you. So I think you can see me now, and you've got my slides up there as well. And thank you. So hello, everyone. My name's Dr. John Griffiths, and I'm a GP. I work in Cheshire, and I'm also the chair of NHS Vale Royal Clinical Commissioning Group. And I want to talk to you this afternoon about what I've learned from the 3 pledges that I've made for NHS Change Day. That was 1 last year and then 2 this year. And my main question to you all is, can you be a change agent? And I want to start by asking the question, why? Why would you want to bother going through all the effort of making a change? And many people maybe sat there thinking, well, I'm all right, thank you very much. I don't need to change anything at all around me. And I want to just challenge that and ask if that's really the case. And I think there are many things, if you stop and think about it, that perhaps aren't working quite so well around you, and things that you might wish to make a change with. Change is not compulsory. Evolution is not compulsory. And extinction is always an option for us. So stop and think, are you really happy with things that you see around you, particularly in your workplace? Are there things around you that you would like to change? There are probably processes in the system that you work in that don't work quite so well as you would like. There might be little things, they might be much greater things. And you may already have thought of a solution, but not done anything about it. And if you stop right now to think, what could you change? What would you like to change? There are undoubtedly things that you could. Do you fully understand what's going on around you? Do you understand how you fit into the wider system around you? I remember when I was a student and I had a summer job working in an insurance company as a post finder. And I was just told a very specific task that I had to get on and to do. And it took me 1 or 2 weeks to work out how on earth my little bit of job fitted into the wider system of what was happening in that insurance company. Is that how it feels for you sometimes? Do you understand how your job fits into the wider system? And possibly even more importantly, do you understand how everybody else's jobs and work fit into the wider system around you? Can you be a change agent? If you can see the things around you that you want to change, if you can see things around you that you would like to understand better, then what can you do to bring about that change and to bring about that understanding? Can you be a change agent? Of course you can. And NHS Change Day is here for you, and that's what it's all about. It gives you permission to make those small changes, and it's for everyone. Anybody can make a change. And I would like to suggest 3 simple steps that you could make to help you lead change wherever you are. To live, to learn, and to lead. If you want to understand something, then live it, experience it, and feel what it's like. So, last year, I placed a day in a wheelchair. So, for me, this was all about a day spent actually in the office. I wasn't doing my clinical work as a GP that day. But what did I experience? Well, I experienced having to wheel myself around an old building with uneven floors and with no lift. I experienced having to sit with a different team downstairs because I couldn't get upstairs to my usual team. I experienced the social isolation that came along with that. I experienced struggling to open heavy self-closing fire doors and struggling to close the door behind me after I'd got into the toilet. I experienced being strapped into a wheelchair taxi. I experienced relying on others to fetch me cups of tea throughout the day because I couldn't get to the tea and nor could I actually carry it on my lap while I manoeuvred my wheelchair. I experienced the frustration at the person who'd left a cleaning bucket in the corridor that I couldn't get past, and frustration at whoever had parked in the disabled bay, so I didn't have room to get out down the disabled access ramp. If you want to be wheelchair friendly or design a wheelchair friendly service, why don't you live this first? Experience what it's like, live it, and understand it. So live, learn, and lead. So learn from it. What do I mean by that? So once you've lived it, once you've experienced it, make sure that you learn from it. For example, this year I spent one of my pledges spending an hour on reception in our surgery. I experienced taking phone calls, making appointments, speaking to people queuing up at the desk, and also receiving urine samples from patients and dealing with doctors' queries. And what did I learn? I learned that it's not an easy job. Although I thought I knew our computer system really well, there were huge parts of it that I didn't know. I learned that there are processes that take place in our surgery that I knew nothing about, such as what to do with those urine samples when a nurse needs to dipstick it, where we keep our controlled drug prescriptions, and what we do with those. I learned that you have to multitask as a receptionist, something that I am not that good at. I learned that the simple task, an idea of logging out of your phone when you're unable to answer it, while you is not as simple as it sounds, which leaves the phone ringing and patients trying to get through not knowing what's happening. I learned that the staff don't stop. Even if the phones do stop ringing, which they don't, and the queue is gone, which it never does, they always find something else to do. So I was able to live and experience being a receptionist, albeit for an hour. I was able to learn from that and share my understanding and learning. Well, the great thing, I wasn't the only person that day to spend some time on reception, so 3 or 4 of the other GPs also decided they would like to spend some time there as well. And one of the main things that came out of this was that the receptionists were delighted and a bit amazed that we had done this. And it made them realise that we took their job seriously and understood the importance of their role. I don't think you can underestimate the impact that that can have. Thinking back to my wheelchair experience, I learned to this realisation that if you can't mobilise yourself somewhere, you can find yourself socially isolated. If you can't get out to meet with people, then you might not meet with people at all. And when you live through something, through experience, you learn things that you were not expecting to learn. So I never thought I would learn about social isolation, spending time in a wheelchair. So live, learn, and then lead. So this year, one of my other pledges was to introduce myself to all of my patients using the phrase, "Hello, my name is Dr. Jonathan." And this was inspired by the campaign started by Kate Granger. And when I talked to my fellow GPs about this, some of them were quite sceptical. They didn't really see the value in introducing myself to my patients at the start of every consultation. And they said things like, well, they know who you are already. You know, they've booked to see you. They've been told by the receptionist who they're seeing. Your name is on the call screen when you call them through, and your name's on the door. And they've probably seen you before anyway, so why would you need to tell them your name? And I wasn't sure that that was the case. And I know for a fact that patients don't always know who they've seen. And sometimes they'll come into my room and they'll say, "Oh, I thought you were a woman," which obviously is not the case. And also they will tell me that they've seen a particular Dr. So-and-so, and looking at the records, that clearly was not the case. So I thought this was worth doing, and so I did it. And I learned that it was well received, that also changed how the consultation felt for me. Introducing myself to my name made a difference. It made things feel less formal and more friendly for me. I found it was a helpful thing. And because I'd done it and experienced it, I could say that with confidence. I could talk about how patients responded positively to this. I can talk about how I've continued to do that. That I now often will give out a small slip of paper with my name on it to my patients when I leave. And I'll write things on there sometimes. So first it tells them who I am, who they've seen. I can write their blood pressure of that day. I can write their blood pressure targets. I can write their diagnosis. I could write their next appointment date and time on there. And you can lead this process with confidence because you have experienced it. You can talk about your experiences with others, like I'm doing today. You can tweet about it. You can blog about it. You can lead it with confidence. And that means you as well. I think we all can lead. You don't have to be a CCG chair or a chief executive. I think you've realised that if you've listened to the presentations today. Anyone can make an NHS Change Day pledge. Anyone can learn from it. Anyone can lead in their organisation. So live, learn and lead. You can do it, so why don't you? Thank you.
Fantastic, Jonathan. Thank you so much for that. That was really, really inspiring. Live, learn, lead. That was a real call to action. Absolutely. Thank you so much. So I'm going to move straight over to Emma, and then we're going to come back and have questions to both of you. I'd now like to introduce you to Dr. Emma Donaldson, and she's going to tell you about her pledge for our patients, what matters to them, and truly hear and act on their responses. So I hope we're able to get you on camera, Emma, and it's over to you.
Well, hopefully that should be coming through now. Thank you very much, Jackie. Can everybody hear that? Is that okay?
Yeah, we can hear.
Okay. Thank you very much for giving me the opportunity to share what I've been doing since NHS Change Day. So I pledged on my birthday, which is the 3rd of March, to ask every patient what matters to them and to truly hear and act on what they said to me. And when I made that pledge, I was a registrar in gastroenterology, and on the 10th of March, I became a consultant. At a similar point in time, my 2 consultant colleagues who look after the liver patients in Salford, one retired and one went on sabbatical for a year. So I became a new consultant with 2 consultants worth of patients to look after, and a pledge to try and act on what they want me to do. So the first thing I realised is that, like a lot of other people, I had a tendency to listen. Can we go back, please? Thanks. With the intent to understand. I was listening with the intent to reply. So when people told me about things that were going on in my service and the service that I was providing, the instinct was to try and defend that service, to explain why we did it that way, why things had to be the way they were, and to explain it away. And what I realised quickly was that in order to fulfil my pledge, I had to learn how to listen, to understand what people were telling me and why it was important, and then do something about it rather than justify the way things were. it's complex. So navigating your way through the NHS is a difficult experience if you're ill, if you've got complex medical conditions, if you're not sure what's wrong with you, if you're frightened or worried or concerned. The system in which you're trying to operate is a massive complexity that's very, very difficult to navigate. So one of the first things that people told me when I asked them is, why do I have to come to so many clinics? So I look after liver disease primarily, and the liver forms part of many people's comorbidities. They have lots of medical problems, and some of my patients are coming to see 4 or 5 or 6 different specialists, of which I am one. And one of the things that we've done as a result of that is try to set up some joint clinics. It's not rocket science, but it's more patient-centred. So for patients whose liver is involved in other conditions, I'll go and see them when they come to see the neurologists. I'll go and see them when they come to see the cardiologists, when they come to see the dermatologists. So they only have to come once. Set up joint clinics for people who've got conditions in which the liver is a part and there's another big component. So they come and see 2 of their consultants simultaneously about their problems and give them less time spent in the hospital and more holistic care. Can I have the next slide, please? Next slide, please. So there's several conditions that we now run joint clinics for. I run a joint clinic with the neurologists, a joint clinic with the inflammatory bowel disease specialists, a joint clinic with the metabolic consultants, allowing patients to come less often. Next slide, please. I think the most common question that I've asked is, can I contact you directly with any questions that I've got? What I think is very common in my practice is relatively rare in general practice, and therefore patients were finding that their GP would say, well, ask the specialist next time you go to clinic, and that's entirely reasonable. When I was ill, I wanted to get an answer when I had a question. So one of the things we have developed is a Hello, my name is card. Again, as part of the Kate Granger campaign, with our contact details on. So I give out my email address to all my patients, and they can contact me directly by email with their queries, concerns. They tend not to come to clinic as often. They're quite happy. They just want to know the answer to a very simple question that's bothering them, even though it wouldn't particularly bother me as a health professional. It meant a lot to me when I was a patient, and it seems to also mean a lot to my patients that they have that backup even when they need it. Next slide, please. The other common things that came up in the next slide, please. The other common things that came up in the clinic was, I can't remember all the things I wanted to ask you, or I won't remember all this information that you've given me. So we've expanded on the personal care files that we use for our cancer patients for all of our patients with long-term liver conditions. In their personal care file, we, similar to Jonathan, we write down the discussions that we have in clinic. We draw pictures and label them so that they can have a look at them when they get home. We put leaflets that are relevant to the tests that they're having or the condition that they have. So we also encourage patients and their families and loved ones to put in their thoughts about their condition, records of their symptoms, questions that they'd like to ask, and then we discuss those when they come to clinic. Again, giving patients the opportunity to own some of their condition and have some control in the consultation appears to have been very well received. For a lot of our patients, I want to be able to see somebody when I have a problem. So clinical problems don't confine themselves to clinical appointment schedules, and a lot of the patients I look after have problems that come and go and require inpatient admission. And these patients were having to attend accident and emergency and coming through that pathway. So we've developed a self-referral pathway to our medical investigation unit where patients with advanced liver disease can just phone up when they need their tummy drained, and we just admit them directly and do it as and when they need us to do it. We can also review their bloods, review their medication, make sure they're okay, involve other services as required. But most importantly, patients and their loved ones can directly access the care that they need as and when they need it. So to summarise, can we have the next slide, please? So here's one of my patients with, tense ascites, really uncomfortable, difficult to breathe, distended abdomen, really painful. Quick and simple procedure to drain all that fluid away makes a huge difference to quality of life, and it can often be difficult to predict when that's going to need treating. So patients being able to phone up and go, I need something doing this week or today or tomorrow, huge advantage for them, less waste for us for admitting people to check they're okay and not needing to go to accident and emergency because they've got a problem. Next slide, please. So in summary, listening causes a lot of work. Having said that, we've got patient-held notes for patients with chronic liver conditions. All the patients have our contact details, so they can phone us and contact us directly if they've got a problem. We've got self-referral in place for common conditions. We've developed integrated clinics. I've started going out and seeing patients with complex disease with their GP in primary care so that their GP is more confident in the times between appointments to be able to help that patient with their queries. We've developed tertiary clinics with transplants so patients don't have to travel from Salford in the northwest down to the West Midlands. We've started early end-of-life planning for patients with advanced disease who have a terminal condition even though that's not cancer. We've developed rapid access clinics to get patients out of hospital earlier but not wait for a routine clinic review, so we can see them as an outpatient quickly as and when they need to see us. We've developed alerts in our electronic records, so when these patients with complex disease come into hospital, we get emailed so we know they're in, so we can go and see them wherever they are in the hospital within 24 to 48 hours of them arriving. So those patients get expert care early in their admission, and the teams looking after them get appropriate support. And we have an MDT every week to discuss these patients and make sure that the ones who need us have been able to contact us. But this is a work in progress, and there's a huge amount more that I need to do if I'm going to act on the things that patients tell me need to change. Can I have the last slide, please? So I think in summary, last slide, please. However difficult it might seem and however much work there is to do, if you change your own practice in the first instance, you can make a huge difference for the patients that you're looking after, at the same time as leading change within your organisation and providing an example of what can be done to your colleagues who might not think it's possible to do it. Thank you very much for giving me the opportunity. Thanks, Jackie.
Yeah, thank you. Thank you very much. Again, another very inspirational presentation. And it was great that you gave it some time on your birthday as well, Emma. So that
I think it's more. It was
3rd of March. We'll all remember that now.
it was a good day to have change day.
Yes, absolutely, absolutely, fantastic. So I'm going to open it up now, see whether anybody's got any questions. But I just sort of thinking about that. I was really struck by both of you, that Jonathan's presentation was live, learning, and live, and you were all about listening to another L, really, living, learning, listening, and leading. And both of you, examples of actually living the change that you want to see. And both presentations, for me, it really struck me that you were both it was a personal impact for you. bringing your kind of personal sort of values, living your values, and also a kind of a personal impact and learning for you. And I just wondered, just as a starter question for both of you, and Jonathan kind of alluded to it in his presentation, was how the impact on other people, and when his GP said, I don't see the point of this, and how you kind of manage that on a day-to-day basis, I think especially as clinicians, and I think especially as doctors. So, Jonathan, can I sort of ask you to comment first?
Yes, absolutely. So you're right, and all of my 3 pledges had a big impact on myself and how I felt about things. And the people that I think I would hope it had the biggest impact on would be my patients, and certainly that I'm hoping is true with my hello, my name is Dr. Jonathan, and it did quite significantly change how those consultations felt in an unexpected way, and it seemed to break down some of the barriers. I was having conversations that weren't just entirely about the medical problem that they were coming with that day, but more about them as individuals and as people. And I know my patients better because of that. I think then it can be a slow process, can't it, in disseminating some of that learning and spreading it out. And I have tried to do that by blogging about it and talking to my colleagues at work, just to say, look, this has made a difference to me and for my patients. And they can then see for themselves whether they want to give that a try or not. And the idea of the slips to hand to patients as they leave, we've talked about as partners, do we get proper business cards drawn up? And we've not gone as far as that, but I'm kind of the pilot in the practice that we may roll that out to in due course.
Yeah, I made my business cards on I'm sorry, Jackie. I made my business cards on Vistaprint on a Saturday afternoon as a bit of a test, rather than waiting for the organisation to design them and print them for me, because I can't remember all the phone numbers that I have to write down. But I would completely echo the hello, my name is makes an enormous difference, and there is something about consciously introducing yourself and setting the consultation in that way that makes a huge difference. There's a question in the chat box about self-referral for other specialties. I don't know. We do a couple. So we do patients with chronic anemia. When they become symptomatic, they can self-refer in for assessment for transfusion and various bits and pieces. And I think heart failure have some pathways as well where they can come in for assessment. But I think just getting on and doing it is the key. Because if you spend your time planning how to do it, A, you'll probably get it wrong, and B, nothing will ever get done. So actually just starting, just doing something, and then next week in the next clinic, just trying something else and just building it one step at a time, you can make a huge difference very quickly.
Great, thank you both. I'm just going to go over to Wayne Connor Shahil. He's got 2 questions. One from Jonathan's presentation. How do we get staff involved in doing things differently and feeling it's part of their mission or their day-to-day job? We start with that one. Jonathan, do you want to take that one?
Yeah, I think it's about giving permission, isn't it, to your staff to make these changes. And that has to come from the leadership that you want to put in place, and being very open and upfront about that, and saying, if you see things that you want to change, we want you to feel enabled to do that, and then leading by example. So, so the staff at the CCG see me as the chair doing these things and talking about them very publicly. And some of these things were big, so the wheelchair was a big thing, to be fair. But hello, my name is a small thing that every frontline member of staff can do. So there are lots of things that you can just get on and do. And I agree absolutely with Emma that it's finding that small thing and making the small incremental changes rather than trying to do some huge thing all in one go. And saying to our receptionist, you know, do you want to come and sit with me in a surgery? Do you want to sit and look how I go through my blood results? Do you want to sit and see how I manage the tasks that you send me on the computer system? What things are going on in reception that you could see done better? And giving them that permission to make those small changes.
Fantastic. And it does, a lot of it, again, comes down to sort of giving permission. And some of it is about our sort of self-efficacy and our belief that actually we can make the change as well. And I think it's those two things coming together. I did say for Emma to take the next one, but actually I've just realised that it is directly to you again, Jonathan, about how much a consultant is engaging with community services and primary care to deliver services in communities in a more streamlined way and in a real patient-centred way away from hospitals.
So I think this is our big challenge, is how we make this shift from work that's been done primarily in hospital settings but actually can be done just as well, if not better, closer to home in a community setting. And we're starting to make that shift, and GPs are feeling that and doing more of that work. And the next step really is how do we get consultants engaged? And I don't have an answer to that one. I'd be very interested to see what Emma, as a consultant, has to say about that. But we've been focusing on community care for the elderly consultants and seeing if we can try and get that kind of role, that generalist role, a specialist generalist in the community, and that's where we've been starting to look at initially. But yeah, I don't know what you think, Emma.
I think it's a big challenge because I think a lot of it's around how we commission and fund and all of those really annoying side bits to actually delivering care to patients. What we've tried doing locally is within my services, we have community services out in general practice for certain groups of liver patients, so patients with high-risk alcohol behaviour and things like that. And what we've just started to do is to set those clinics up on a rotational basis in GP practices, so patients can choose to have their next available appointment, wherever it might be, or they can wait until the clinic rotates through their GP practice, and we'll see them in the community. And that gives us huge opportunities to then, have lunch with our GP colleagues and talk about people that they're worried about or people that we've got on the books together and see those patients together. I've got a couple of patients now that I go out into primary care and see the patient when they attend their GP, because the secondary care bit is complicated but certainly doesn't need to be done in hospital, and the GP is much more important for that patient in their long-term overall health care. And my bit is tiny but difficult for the patient to understand and very, very rare in terms of general practice and what you might see on a day-to-day basis. But they don't need to come to hospital for those appointments, and those appointments are much better being undertaken with the GP. And those patients that we've started doing that with have reported huge benefits from actually feeling like it's not all being done by telephone and email and handwritten letters and having that link there in a more established way. And I think we need to be creative about how we do it, but it needs to be done. I don't think I do anything in my clinics that couldn't be done in primary care, but I also wouldn't expect the GPs to look after all my patients. I think that would be unfair.
And so for me, it's about how we make that care more joined up right across the pathway, isn't it? So,
yeah, absolutely.
And we have these artificial boundaries that patients don't see between why do I have a primary care need or a secondary care need today or a social care need. Actually, they've just got a need, and that needs to be met by somebody who do that in a more intelligent way.
Exactly. Yeah. And I think some of that is about reframing as well. And it's just got a need. I've got exactly. So. Has anybody? Thank you both. Has anybody else got a question, or Wayne? Is there anything else that you want to kind of reflect on as you ask questions, is there anything you want to say? No? Okay. Any more questions? Anything in the chat box or on Twitter that you want to reflect? No? Okay. So I'm going to give Emma and Jonathan just to kind of, just your last words really that you want to share, and then we're going to do a round of applause. So Emma, do you want to go first?
I think that you just need to get involved. I think just do it. Don't look for consensus. Look for something you can do as an individual that will make a change for patients or raise awareness, and it doesn't matter how big or small that is, but just do something rather than talk about doing something or think about doing something. Actually just do it. It's exciting, it's quite addictive, and it's a hell of a lot easier than you think it's going to be when you look at it from the outside.
Absolutely, and I remember when we did the first change day, that was my mantra in the office was, oh, just do it. We broke every rule in the book, but it would never have happened if we didn't. And thank you for that, Emma. And from you, Jonathan?
It's exactly the same. And I'm going to say, of course, live, learn, and lead. And the fact that actually we are all leaders and we all can be leaders. You don't have to be the CEO, top of your organisation. Anybody can make that change, and if you've done that, you can lead the change for everybody else.
That's fantastic. And just to follow up from Jonathan's presentation, one of the call to actions that we think will probably spring out of Change Day is a call to action around the use of wheelchairs and more access for wheelchairs. So really looking forward to that, and if anybody wants to get engaged, and I've already asked Jonathan that, so that's fantastic. So I hope, Alison Phillips, that answered your question, one message from either of the panellists, what they can share and what that was. And can we give them a virtual round of applause, and just to thank you both for such an inspirational presentation. So thank you very much. It was great.
Thank you. It was a pleasure.